Hello and welcome back. This is the third slideshow for Philosophy 125. This lecture slideshow is for item 3 on the syllabus. Our topic question is, why are most scientists and physicians so negative about alternative medicine? These slides cover approximately the third week of the course. For this set of slides, be sure to read Chapter 1 of the Akasha text and review Handout 1, Sections 6 through 15. Watch this video, The Alternative Fix. There is a link to it in Canvas Module 1. You'll need to watch this video before this slideshow. I assume you have because I've asked you in a discussion a couple of questions to motivate your thinking about what goes on in this video. So here are the questions I've asked you to think about and discuss. Number 1, what are some arguments that proponents of alternative medicine give? In your view, are these arguments good or bad? Why? Alternative medicine, AM, is just not mainstream or sanctioned by established or conventional medicine. Let's define alternative medicine loosely for the sake of discussion. Presume that any therapy or treatment designed to reduce or heal suffering, which isn't mainstream, accepted by established medical practice, anything that's not endorsed or practiced by conventional medicine is alternative. It's not an exclusive or perfect distinction, but it gets us started. Realize that once an alternative therapy becomes accepted, some do, it gets integrated into conventional practice and can become conventional. Alternative medicine is also called integrative or complementary medicine, or natural or holistic. Integrative medicine contrasts with mainstream conventional or allopathic medicine, though these need not be competitors. There isn't a clear line worth imposing in our discussion. Some versions of alternative medicine are becoming mainstream. For example, some health insurance covers some forms of chiropractic manipulations. Here are some examples of alternative medicine: herbal or vitamin supplements, acupuncture, aromatherapy, chiropractic, homeopathy, hypnotherapy, meditation, Reiki energy healing, yoga. Some allopathic or mainstream medicine examples: prescription drugs, physical therapy, exercise, radiation therapy, surgery, psychiatry. Now, alternative medicines and therapies have benefits. Alternative medicine offers hope for those who suffer. Alternative medicine appears to have positive outcomes. Alternative medicine costs less than conventional interventions sometimes. Are such benefits enough to justify using alternative medicine? So this is an issue. Lots of rationales, reasons for doing something, depend upon false or dubious assumptions. True or false? Somebody says, if it can't hurt and it might help, then you should try it. Realize that a treatment could apparently not hurt you and appear to be helpful, and yet you might not want to try it because it is expensive or actually unsafe or ineffective. Here are some benefits of coffee enemas. You'll remember these from the video Alternative Fix. People report these positive outcomes, yet none of these claims has been rigorously tested. People say, if giving oneself coffee enemas can't hurt and might cure one's cancer, then you should do them. However, self-administered enemas always risk a torn rectum or bowel, colitis, nausea, vomiting, diarrhea, and interference with normal absorption of water electrolytes. Is this a good argument? If X is unsafe, then people should stop using X. For X, consider acupuncture, chiropractic, herbals, meditation, homeopathy. Well, people have not stopped using X. Therefore, X isn't unsafe. Take a closer look at Claim 1. Is it true? An argument is only as good as its weakest assumption, and this claim has serious exceptions. For instance, people continue to smoke, drink, misuse drugs. See Handout 1, Section 12 for more examples against Claim 1. Egyptians, Greeks, Romans, and the Chinese have used Aristolochia to prevent seizures, increase sexual desire, boost the immune system and start menstruation. People also treat snakebite, intestinal pain, gallbladder pain, arthritis, gout, achy joints, rheumatism, eczema, weight loss, and wounds with it. But Aristolochia is unsafe. It's toxic to the kidneys and causes cancer. It increases greatly the risk of bladder cancer and other urinary tract cancers. It's banned in Germany, Austria, France, Great Britain, Belgium, and Japan. In the US, the FDA seizes any product containing aristolochic acid. Again, let's look at this argument. Is it any good? If X is unsafe, then people stop using X. People haven't stopped using X, therefore X is not unsafe. Now, this argument is valid in form, which means that the conclusion would definitely be true, claim 3 would definitely be true if claims 1 and 2 are true. But claim 1 is not true. It's actually false. We can think of exceptions. We can think of things that are actually unsafe and people continue to use them. So it's a bad argument. Can you think of some unsafe therapies that people continue to use? Consider vitamins and mineral supplements, whether or not we need them. Scientists have looked at lots of these, and after many large-scale randomized trials, find that there is no overall benefit from taking supplements. In fact, some studies show an increased risk of cancers in relation to using things like vitamins. Here's another argument. If X is natural, then X is safe, effective, good. Well, X is natural. Therefore, X is safe, effective, good. Can you show exactly how this argument fails? Look again at claim 1. Think of some natural things that are not safe, effective, good. Any argument that depends on a dubious or false assumption is bad. Berries of dogwood and nightshade, wild cherries, buckeye nuts, wild almonds all contain toxic compounds. You don't want to eat those. Of course, the dose makes something lethal or not. Still, just because something is natural does not make it good. War, famine, disease, death are also natural, and we do not think these are good for us. Fire is natural, so it must be good for us, right? Consider these statements from people in the video Alternative Fix. After taking the supplements and doing the coffee enemas, my cancer disappeared. This was the female patient who was undergoing the Gerson treatment, the one with the coffee enemas, and the megadoses of vitamin supplements. But realize it isn't clear that the woman in the video actually even ever had cancer. She never got confirmation by a biopsy. I feel better, so something must be working. Lots of patients say this, after acupuncture, for instance, chiropractic, herbal supplements. But is this evidence? People also feel better without treatments. People feel better for reasons other than the treatments that they administered. So look out for this kind of reasoning. We'll call it after this, therefore because of this reasoning. It's also known as the post hoc fallacy. That's the Latin phrase for it. Let me show you what that is. Here's an argument. Is it any good? Event C happened immediately prior to event E. Let C stand for alleged cause and E stand for event. So C probably caused E. Here's an example. I consumed 1,000 milligrams of vitamin C daily all last winter, and I never got a cold. So, taking the vitamin C prevented colds. Now, what's the assumption here that's problematic? The claim 2 I have here on the slide. Insert false assumption here. Claim 2. Can you say exactly what this assumption is? It's going to be an assumption that joins claim 1 and claim 3. Let's look at the entire argument. It goes something like this. Event C happens immediately prior to event E. If C, some alleged cause, happens prior to E, then C caused E. Therefore, C probably caused E. Now, it's claim 2 that's the issue. It's saying basically if something happens prior to what you're trying to explain, then the thing which occurred prior to what you're trying to explain is the cause of what you're explaining. I mean, it's possible, sure, sometimes this is the case. But what other explanations are there before we leap to the conclusion that the thing we notice occurring prior to what we're trying to explain is the actual thing which caused it. What's correct here is thinking that effects always come after their causes. Of course, it is necessary that causes precede their effects. But that a possible cause precedes an event is not enough to show an actual causal connection. It's not enough to show that the one thing causes the other, just because it comes prior to the thing you're trying to understand or explain. It could be coincidental. It could be caused by something else. Are these good arguments? Here is that reasoning, that flawed reasoning. My back pain went away a few days after the chiropractor manipulated my spine, so chiropractic works. Another example. When roosters crow, the sun rises. Therefore, roosters cause the sun to rise. See, their crowing causes the sun to rise. These are examples of after this, therefore because of this reasoning. Think of your own clear but absurd examples to show others this error. Here are more sophisticated examples. Is this a good argument? The only policy that effectively reduces public shootings is right to carry laws, right to carry firearms. Allowing citizens to carry concealed handguns reduces violent crime. In the 31 states that have passed right to carry laws since the mid-1980s, the number of multiple victim public shootings and other violent crimes has dropped dramatically. Murders fell by over 7%. Rapes fell by over 5%. Aggravated assaults fell by 7%, and robberies diminished by 3%. All right, look at that argument. All we observe is the decline in shootings after these laws pass. But what else could explain this? It is hasty to accept this explanation. In fact, these statistics might require no explanation at all. This could just be within the realm of the variation we see over time where people commit these crimes. Here's another argument. Call this example 2. Evidence shows that even state and local handgun control laws work. For example, in 1974, Massachusetts passed the Bartley-Fox Law, which requires a special license to carry a handgun outside the home or business. The law is supported by a mandatory prison sentence. Studies by Glenn Pierce and William Bowers of Northeastern University documented that after the law was passed, handgun homicides in Massachusetts fell 50%, and the number of armed robberies dropped 35%. Again, notice all we observe in this example is the decline in homicide and robberies after the laws passed, after the gun control laws passed. Well, what else could explain this? What have we done to eliminate rival explanations? Nothing. All we've got here is a correlation. All we've got here is this statistic decreased after gun laws. But we've not shown that it was the gun laws that did it, or even that it needs explaining at all. In fact, it could also be multiple causes, and it may not at all have anything to do with gun laws being passed. It's just not enough for us to like one explanation over another, just because a positive outcome occurred after a perceived change happened. To be clear, any actual causal connection requires an observed correlation, a correlation between events. But correlation alone cannot establish a causal connection. We need to induce the effect from the alleged cause under experimental circumstances, where we control for subjective bias and statistical errors, for instance, small samples. I'm going to say a lot more about this when I talk about peer-reviewed randomized controlled trials. Let's talk about homeopathy. This is an alternative medicine that is used to treat chronic pain, allergies, asthma, even warts, acne and age spots, PMS, menopause, and of course anxiety and depression. Homeopathy. Dilutions of substances can remedy the sick and keep the healthy well. This is the assumption. Homeopathy is alleged to work because of the law of similars. It's the idea that like cures like. That is, a substance which causes symptoms of a disease in healthy people will cure similar symptoms in sick people. For example, Give stimulants to the overstimulated, this will calm them down. Homeopathy presumes that effective remedies produce symptoms in healthy people similar to those of the diseases that they treat. So using ultra-high dilutions of an otherwise toxic substance alleviates or cures disease. Think of the example in the Alternative Fix video where the physician used massive dilutions of tarantula to treat hyperactivity. The severity of allergic rhinitis, runny nose, itchy nose, and eczema, dry skin, sometimes declines after homeopathic treatment. But is this good evidence that homeopathy works? Homeopaths prescribe onions as a remedy for the common cold and hay fever because it causes tearing of the eyes and dripping of the nose. But does it work? Over and over, studies find insufficient evidence for this. As I see it, there are three philosophical problems with homeopathy. First and foremost, the most common argument for homeopathy is that after using a homeopathic remedy, some people feel better or healthier. But this is faulty post hoc reasoning. After this, therefore, because of this reasoning. We need studies where we have control groups and experimental groups whose members do not know whether they got the homeopathic remedy or a placebo. A sugar pill, that is, a substance that has no therapeutic effect. When we observe no significant difference between the two groups, it is actually as if homeopathic remedies work as well as treatment with a placebo. And lots of times, people's own immune systems restore their health. So we don't know whether it's the immune system of the person, the homeopathic remedy, or something else. Further, the idea that like cures like is too vague to explain why some people feel better after homeopathy and others don't. In fact, most people do not feel better after homeopathy. Even so, the opposite is also true. Like does not cure like. For example, more poison does not cure poisoned people. More alcohol does not cure alcohol intoxication. In fact, it kills people. 1,800 studies have been reviewed most recently by scientists, and they conclude that it doesn't work. This is not to say it could never work. It's also possible that these studies, it's a lot of studies, it's also possible these studies didn't see it working. The reason we conclude that it doesn't work is we don't see it working when we should see it working. At least we should see a difference in the outcomes for people who used homeopathic treatment versus those who did not. They see no difference between the experimental and control groups. That's a pretty good reason to say probably homeopathic remedies of specific sorts do not work. You can't say it doesn't work just because you don't see it work, but if you set it up so that you should see it, you should see a difference, and you don't, that's a pretty good reason to doubt that it works. Again, you don't show it doesn't work, but now you show you've got inadequate reason to believe that it does. And here's the summary statement in the systematic review, and I'll say more about this later. I have some videos for you I want you to see. Based on the assessment of the evidence of effectiveness of homeopathy, NHMRC concludes there are no health conditions for which there is reliable evidence that homeopathy is effective. Homeopathy should not be used to treat health conditions that are chronic, serious, or could become serious. People who choose homeopathy may put their health at risk if they reject or delay treatments for which there is good evidence for safety and effectiveness. People who are considering whether to use homeopathy should first get advice from a registered health practitioner. Those who use homeopathy should tell their health practitioner and should keep taking any prescribed treatments. Here is a systematic review you can take a look at. This occurs in the British Journal of Clinical Pharmacology from 2002. This concludes that the best clinical evidence for homeopathy available to date does not warrant positive recommendations for its use in clinical practice. But see the article itself. Here are my references. What about smart people who support the use of alternative medicine? Heart surgeon and TV celebrity Dr. Oz advocates alternative medicines and promotes paranormal practices. But is he a credible, reliable source on this? According to Dr. Oz, Raspberry ketone is the #1 miracle in a bottle to burn your fat. But is he an authority on this? As a heart surgeon, he knows about cardiovascular disease and how to repair heart valves, but he has no formal training or certification in nutrition. Yet his credibility as a doctor carries over into areas of healthcare and fitness, within which he does not do formal research or published work. He is not regarded as credible or reliable within the scientific community on anything other than cardiology. Is this a good argument in response to noting that his peers disagree with him? Medicine is a very religious experience. I have my religion and you have yours. It becomes difficult for us to agree on what we think works, since so much of it is in the eye of the beholder. Data is rarely clean. You find the arguments that support your data, and it's my fact versus your fact, Dr. Oz. I want you to watch this short video, Dr. Oz and Nutritional Supplements. This appears on the blog page. Recall our question: why are most scientists and physicians so negative about alternative medicine? The short answer: stories about positive outcomes rely on post-hoc reasoning and observations with little or no control for statistical or psychological biases. Alleged associations are correlations only. As such, they are insufficient to justify believing untested therapies that they actually work or are safe. So summarizing, why don't most scientists and physicians take alternative medicine seriously? Either they conspire unfairly against alternative medicine, or they have rational reasons for being skeptical. Even if one believes sincerely that alternative medicine works or that alternative medicine is harmless, you might be mistaken. You risk serious harm if you use a substance or undergo a procedure with unknown risks. Without tests or peer-reviewed randomized controlled trials, I'll use the acronym PRCT, there's no rational objective reason to accept any alternative medicine claim as scientific, at least not yet. What is a peer-reviewed randomized controlled trial? For more detail on these terms and many, but not all of the scientific terms we use in this course, see my Scientific Terms You Need to Know page. This is a glossary that I have for you within Canvas Module 1. In science, controlled observations override speculation or personal stories. Scientists prefer results from PRCTs before they take seriously any hypothesis asserting that some specific therapy or procedure or medication remedies a problem. As long as an alleged remedy's effects fail to be observed in a PRCT, claims about its usefulness or safety are not adequately supported. Any such claims might be true or might be false, but remain unproven until it is tested under controlled circumstances. That a therapy might work or apparently make some subjects feel better is not enough. As in courts of law, we must defeat reasonable doubt because we seek efficacy and safety. A positive study result remains dubious even when tested, especially if it corresponds with no greater measurable effect than that predicted by chance. Or the therapy shows no better result than those obtained by the use of an inactive placebo in a comparable group of subjects. Again, placebos have no effect. Other rival therapies already show demonstrably positive results given PRCTs. So unproven means untested. Among scientists, to say that a claim is unproven is saying that it is untested, preferably by a PRCT. Proof or prove derives from the Latin term for demonstrate. So an unproven claim is one that as yet has not been demonstrated sufficiently by evidence or argument. So what is science? One way to answer this is to say what it isn't. It isn't unsupported speculations, however credible or plausible. Untested, unsubstantiated claims are not science. Until a study is peer-reviewed or published, reviewed by experts, it is not science. Science cannot assess claims about any allegedly unobservable, non-physical, or supernatural entities. So science cannot accept or reject their existence and cannot accept that any such entities have physical effects. Certainly people can, but the methods of science can't. Let's talk about garlic. Consider the possible medicinal effects of garlic supplements. Let's look at a peer-reviewed, randomized controlled trial with a precise hypothesis being tested by looking for significant differences between control and experimental groups, where control groups do not consume garlic, but experimental groups do. This is from a 2007 study, The Effect of Raw Garlic versus Commercial Garlic Supplements on Plasma Lipid Concentrations in Adults with Moderate Hypercholesterolemia. This is a randomized controlled trial, and you can see the paper in Canvas. In science, evidence that passes peer-reviewed, randomized controlled clinical trials is the gold standard for claim acceptance. Here are some things people say about garlic: that it repels demons, the evil eye, vampires, and insects, especially mosquitoes. Garlic is said to protect from colds, tuberculosis, and treats digestive and menstrual disorders. Garlic combats cancer, senility, and erectile dysfunction. Garlic alleviates the symptoms of allergies and asthma. Garlic consumption lowers cholesterol. Let's focus on that last one. That's one we can test. It has been tested. If garlic has any of these curative properties, we ought to be able to observe and measure its effects. Who cares? Cholesterol is a waxy substance found in the fats, lipids, in your blood. While your body needs cholesterol to continue building healthy cells, when you have high cholesterol, you may develop fatty deposits in your blood vessels. Previous studies have found that hypercholesterolemia is associated with an increased risk of heart disease. It is diagnosable and treatable. Garlic might have an effect on cholesterol, but we can't just assume it does. We need to power a test which allows us to reject the default claim that it does not lower cholesterol. And by default claim, I mean this. For anything someone says has certain curative properties, first we assume it doesn't, and then we look to see if maybe it does in a controlled study. Some definitions. What's a hypothesis? A hypothesis is a supposition about a specific issue. What's a null hypothesis? This is the supposition that there is no significant association, correlation between two or more variables. Studies are usually powered to reject the null hypothesis. If someone says taking vitamin C reduces colds, then we presume that it doesn't, and we power a study to show that in fact it does, which causes us to reject the hypothesis that it doesn't. The alternative hypothesis is the opposite of the null. That is, that there is an association, so we have a choice at the end of a study. If it's powered well enough to help us reject the null hypothesis, then we accept temporarily, tentatively, the alternative hypothesis. A statistically significant result is the following. It's the likelihood that an observed relationship between two or more variables is affected by something other than chance. For any research findings, answer these questions. Number one, what is the issue? What's the subject? Number two, what specific hypotheses is the study powered to prove, that is, test? Number three, what is the main conclusion about the hypothesis? Number four, what is the argument for the conclusion, for that conclusion about that hypothesis? Number five, what can we conclude about the issue and why? Here are answers about the garlic study. What is the issue? It's whether certain amounts of consumed garlic, raw or otherwise, lowers cholesterol. What specific hypothesis is the study powered to prove, that is, test? A specific amount of garlic lowers cholesterol in people with mildly high cholesterol levels. The null is that garlic does not lower cholesterol. The null hypothesis is your default hypothesis. You presume it doesn't until you see evidence that it does. The alternative hypothesis then is that a specific amount of garlic lowers cholesterol in people with mildly high cholesterol levels. What's the main conclusion about the hypothesis? Specifically tested under controlled conditions, amounts of consumed garlic don't appear to lower cholesterol. What's the argument for their conclusion? Tested amounts of garlic don't appear to lower cholesterol levels in people with mildly high cholesterol, because there's no observed difference in cholesterol levels in people who consume the garlic versus those who do not. In short, they don't see a difference between the groups that get the garlic versus those that do not. What can we conclude about the issue and why? No effect observed yet at this dose. We need further tests before we believe garlic lowers cholesterol. Scientists do not even find a correlation between garlic consumption and lower cholesterol, which they should see if it did in the experimental group. Thus far, we have no reason to believe garlic has this effect. It might not. Okay, in the garlic study, in any study where we want to provide evidence that a substance, say, lowers cholesterol, what we need to do is be absolutely clear about what it is we're testing, what it is we are asserting. We need a hypothesis which is testable, rejectable actually. Below, I have two versions of what we need, namely the null hypothesis. I frame the null hypothesis here since it is the one the study is powered to test, which means we reject the null if we actually see what we presume we will not see. Before a study, we don't expect to see a lowering of cholesterol in the experimental groups, and if we do, we reject the presumption. We reject the null hypothesis. So let me be clear here. Again, two groups, experimental groups, several of those with various doses and varieties of garlic, and a control group where people get a placebo, something that tastes like garlic in their diet, but they actually don't get the garlic. So the control group does not get the garlic. Both groups, all groups that is, have mildly high cholesterol. And what we want to do is induce a lowering of cholesterol in those that receive garlic versus those that do not. So let's take a look at these hypotheses. One version is not so good. It's the one that says eating garlic does not lower cholesterol. Again, the negative form of this is so that if we see the opposite, namely we see a lowering of cholesterol, then we can reject the view that it doesn't work. Eating garlic does not lower cholesterol. Sounds good, but it isn't. It's vague. It's not specific about doses, duration, etc. We need to be more specific, and remember the study, when you look at it, it tells you exactly what it does. Let's include those details in framing the null hypothesis, which was tested. Eating a 4-gram clove of raw garlic per day, 6 days a week for 6 months, does not lower average low-density lipoprotein cholesterol levels in the blood of most adults with mild hypercholesterolemia. So notice this is talking about adults, people with mildly high cholesterol. They took it for 6 months, not longer, not less, 6 days a week, and the dosage was a 4-gram clove of raw garlic or some other form of garlic. This is precise. This is more easily tested and rejected. Go back and look at the study, its results, and then its conclusions, and you'll see that they saw no difference, no statistically significant difference between those that ate the garlic and those that did not. All of the groups, all of the people had mildly high cholesterol, and they saw no difference. That's a pretty good reason to not believe that garlic lowers cholesterol when you set it up so that you should see it if it does. And you could criticize this by saying, well, they didn't give enough garlic or they didn't eat garlic for long enough, right? That would be a separate hypothesis. A later study can test that. I mean, there's only so much money and time. This is a pilot study. This is where we try to find a correlation and association. In this case, this study and subsequent studies failed to find any association, any correlation between eating garlic and lowering cholesterol. Summarizing here, unproven equals untested. When we say there's a link, say, between consuming garlic and lowering cholesterol, we are saying there's some kind of association. And the fancy statistical language is we say correlation. A link, an association, a correlation, that's all the same thing. But be careful. Causation requires a correlation, requires that we observe a correlation. In fact, in a peer-reviewed randomized controlled trial, what's required is that we actually induce the effect we're looking for. Correlation does not require causation. You can have a correlation, and that correlation, that association could be coincidental. It could be illusory. It could be that some other thing is causing both factors which you think are actually the one causes the other. Here are 3 requirements for establishing probable cause and effect relations using peer-reviewed randomized controlled trials. Number 1, you've got to see a correlation. You have to demonstrate a correlation between the independent variable, a specific causal factor, and the dependent variable, a specific effect. No correlation, no causation. In the case of the garlic study, the independent variable is the garlic, some dosage of garlic. And the dependent variable, the lowering of the cholesterol. Number 2, determine the time order of variables. Again, we're trying to relate those variables. Let's assume we see a correlation. We have to show that an alleged cause actually precedes the effect we want to explain. Seeing smoke, then a fire, does not imply smoke causes a fire. So you have to make sure that what you want to explain comes after what you think might be causing it. Number 3, and perhaps this is the most important, you need to rule out alternative explanations for the observed correlation. We have no business accepting one explanation over another simply because we like it or because it's simple or it's the most popular. We have to consider other explanations. We have to do a variety of tests to eliminate explanations before we converge on one we like, we think explains best. And again, even that one's tentative. When a better explanation comes along, we ought to accept that one over the previous one. When I talk about ruling out alternative explanations, I'm also talking about how sometimes we see 2 variables, 2 factors correlated, and yet the connection is quite different than we expect. For instance, think about obesity and depression. They are correlated. They are linked. We see in many cases obese people are more depressed. We see among depressed people more obesity. But before we say obesity causes depression or the depression causes obesity, and while those might be factors influencing each other, both may have a common cause. For all we know, there's something environmental, genetic, or some combination of multiple factors. So we got to demonstrate a correlation. We need to demonstrate that, in fact, what we're trying to explain comes after what we think might explain it. And third, we need to consider alternative explanations and reject them before we accept the explanation we think explains best. I have more to say about this. I have an article for you to read in Canvas C1D, 3 Steps to Establishing Cause and Effect in Module 1. The following 2 images summarize the main types of scientific evidence and some common reasoning errors and biases that can make scientific claims incredible or just plain bad. These images are also available via hyperlinks at the end of Handout 1. First, look at the one called A Rough Guide to Types of Scientific Evidence. In this slide, you can't see it too well, but again, look for it in Canvas. Look for it on the Handout 1. Here is a rough guide to spotting bad science. Here are 12 problems. So whenever you hear a new report about a study showing that some factor increases or decreases the risk of something, you need to find the primary source first, and then determine whether the study is a peer-reviewed randomized controlled trial or not. I mean, that's the gold standard. There aren't many of those. They're expensive. They're not perfect, but scientists regard those as the highest form of evidence. Most studies you see, most associations, correlations found, are from another kind of study, one which cannot establish that one thing causes another. However, they can establish that there's a correlation which needs explaining and which will motivate us to do further study, namely provide randomized controlled trials where we test hypotheses about possible causal relations. Again, observational studies are designed only to find associations, not causes. Up next, we're going to talk about scientific standards. Some studies are better than others, but all studies have weaknesses. In an effort to rank the merits of each kind of research effort, various evidence hierarchies, an evidence pyramid, for instance, illustrates the relative strength and reliability of scientific research efforts. All research studies are not equal. At the top of the pyramid is going to be the best kind of study, but least available kind of evidence, including peer-reviewed randomized controlled trials. Below peer-reviewed randomized controlled trials, observational studies, etc., are the weakest, most abundant, although their findings are useful for future, more focused and systematic research. My point, observational studies find associations or correlations. That's great, say between drinking wine and reduced blood pressure, but they do not establish or even test whether claims about one substance or treatment or factor actually causes any specific effect. Media headlines say this. People who are not careful when they read these studies say this. Scientific journalists sometimes fall into this sort of sloppy way of thinking writing. We need peer-reviewed randomized controlled trials to show a real cause and effect relation. Is an example of an image I'm going to use which shows diagrammatically the hierarchy of evidence. Observational studies occur below peer-reviewed randomized controlled trials. Systematic reviews and meta-analyses, I'll say what those are. I've got a couple videos on those for you, short videos. These are going to appear in the blog. I'm also going to use some of those in discussions. Systematic reviews and meta-analyses are actually about findings derived from randomized controlled trials. Below this, cohort studies, case control studies, case series, case reports, all of those are observational studies, and so they are less reliable, less credible. Still good, much better than people telling stories about their own personal experiences. And that's the end of slideshow 3 for week 3.